I have Shri R. Prasanna, who's the Secretary of Higher Education, Department of Government of Chhattisgarh, India, an IS officer involved in the design and implementation of programs in several departments, including health and overall rural development. Professor Kadri, a public health leader and an epidemiologist with expertise in disease control and technology in healthcare. Thank you, Professor Kadri. Dr. Amrita Gupta, a public health professional focusing on disease prevention control strategies, NCDs, and other public health programs. Ms. Nihita George, a health systems migration and adaptation consultant at Healthcare Without Harm, India, focusing on climate adaptation and migration within the healthcare sector. And Dr. Bhuputra Panda currently serves as Professor of KITS, School of Public Health, Bhubaneswar, India, and also is part of the INODA, Institute for Health System Strengthening. I have our very own Iman, who's going to be here to moderate the session. She's an associate director at Access Health International and works on health financing climate, and she will introduce the session and take it forward.
Good morning, everyone. I believe that's just 6 minutes before it's the afternoon, and I'm going to keep it short because it's this session between us and lunch. Good morning. 12 months ago, we convened to discuss various dimensions that need to be considered when planning for climate adaptation. Last year, we looked at matters such as planetary health, structural resilience, building trust in indigenous communities such as the Maori, vernacular architecture, passive cooling technologies that should probably be considered in countries contextually, as well as water scarcity's impacts on women. We also discussed the gaps across policies, notably in South and Southeast Asia, in terms of health and national adaptation plans. Now, while we addressed several aspects in terms of disaster response, surveillance, coordinating mechanisms, what was notably absent in all of these plans was recognizing specific communities and these specific communities' needs. And echoing what was said in the first session, resilience can only be achieved if we target these actions at the primary care level on the ground with communities. So today, what we will be doing is connecting what we learned in the last year and go further down into action level insights. We will revisit the focus on specific community needs of tribal communities and also how plans are turned into action at the health facility level, including sustainability efforts that can amplify climate resilience planning. So without further ado, I'd like to invite our first speaker, Mr. Prasanna, to give his talk. Thank you.
Yeah. So I'm just sharing a small presentation about what we are doing in Chhattisgarh with respect to impact of the climate change. So after the COVID, I think climate change is also being taken very seriously. At least at the discussion level, at the state level, things are shaping up and it's coming up. But I'm just going to give a brief idea about the implementation, how it is happening up to the PHC level and what needs to be done in the future to improve it. So right now, we have started with the surveillance of different aspects of climate change, especially the heat-related thing has taken the top priority in the present system. So we are, with the help of the data that are provided by different departments, so we are mapping the changes in the heat that is happening in the various parts. And also based on the patients that are coming till PHC level, PHC and above, we are also documenting the impact of the heat that is happening at the field level. So this is the temperature variation that we are mapping up at the district level based on the data. And below district level, we have still not gone, whereas in the future, we'll have to capture even up to block level and if possible, below the block level at the facility level, so that we'll be also able to get the actual information about the subclimatic variation that are happening in different parts of the area. And Chhattisgarh being a forest area with 44% forest cover, and with the development where the forest takes a beating, then what is the impact of these climate changes because of the deforestation and the industrial activity that is going on? That will be visible only if you are able to catch data at the sub-block level facilities. So this is the average that for every month in the last 1 year that we have been calculating. And Chhattisgarh being having a very heavy industries and also the thermal energies, we have lots of thermal power plants in the state. So earlier we did air quality surveillance for 2 districts, one in Raipur and one in Korba, based on which the 2021 report was published. And now we are actually having surveillance of in 8 other districts, based on which the report will be submitted shortly by Government of India. So similarly, we are actually also documenting the rainfall pattern that is happening, changes in the rainfall data. And based on that, what is the impact that they are having on the different diseases? So this we are trying to map with malaria, but unfortunately, what the data that is showing here and the impact because of climate change is not capturing, because in the last few years, the government, malaria being a very high problematic disease in the state of Chhattisgarh, it was taken on a top priority. And we had several campaigns to reduce malaria cases. So because of which the malaria cases have gone down drastically. So though the temperature variations and other things, the cases should have gone up, but it is showing downfall. That is because of the other reasons. So this is a data of one of the tribal districts called as Sarguja division. With respect to how we are bracing for the climate change, so initially we started with going for solar electrification of all our hospitals. So we have so far done almost around 900 government facilities. We have provided solar facilities, so which reduces the conventional electricity demand, for which we were awarded also. And also we are trying to convert our hospitals into climate smart hospitals, and we are in the process of getting the proper certification of one of our primary health centers in the northern district of Chhattisgarh shortly. So in the years to come, because even the hospitals have an important role to play in the climate changes in the way they function. So we are taking care of that aspect also. So these are all small interventions that have been happening in the state of Chhattisgarh. So what we are planning right now is that earlier also, when we wanted to improve the health system strengthening in the hospitals of Chhattisgarh, we identified one important diseases, and to address those diseases, then we started working in strengthening the facilities, by which we are able to strengthen all the hospital facilities in a shorter time using the available resources. So similarly, if we're able to catch one important health parameters because of the climate change, maybe for example the temperature variation, the heat stroke, then if you start working on those issues, then we'll be able to easily strengthen the health facilities for all the other related diseases also, which will happen because of the climatic changes. But the main challenge is going to be the already existing problematic diseases, because all our resources and times are devoted to these things. The how to overcome that challenge and also plan for the future is the biggest challenge. And generally our emergency response structures are poor, except during the COVID time, when we are able to the response time we were able to build it. So now we'll have to have a proper emergency response designed for the future emergencies. So right now, even if you take care of the heat-related issues, the labor room, the postnatal wards, and other things don't have a proper cooling facilities below the district hospital levels. And also the training needs to address these things have not been incorporated to the health workers because the present training need for the existing government of India priority schemes itself takes a lots of time. So we are not able to give dedicated training for the health staff for these things. And also the data systems that we have currently don't capture all these data. So we'll have to work on those data system also to improve planning for the future. So these type of small questionnaire we have planned to design so that at the hospital level also they'll be able to start implementing for the future health needs. These days, because of these Kayakalp awards and other accreditation facilities, many of the health facilities on their own are also taking lots of interest to improve their health facilities. So once these type of checklist is prepared and the health team are trained for these things, then they'll be able to manage at their own level also. So right now we have a state level health plan for climate related issues. Now we'll have to design a proper implementable and actually practical plan for the district level and also at the hospital levels also. And also the awareness for these issues is still not ready, though we know the impact of these climate related issues because of the day-to-day changes in the climatic factors. But the awareness for the health related thing is still yet to come. So we have to do lots of IEC activities and surveillance has to be improved so that we have data-based decision making in the future. And we have to simultaneously work on improving the health facilities preparedness for these things in the times to come. To take this forward, right now I'm looking after higher education department, and we are planning to even document the Indian knowledge systems, how the communities in the earlier ages used to take care of their healthcare needs whenever there was a change in the climate change. So similarly, we are trying to document these things using by colleges and universities also, so that because all the treatments cannot be hospital based, so we'll have to involve the community so that it is easier to manage and it's also cost effective. So we are planning to work in that also. Thank you.
Thank you, Ms. Prasanna. I would like to invite our next speaker, Dr. Kadri. Thank you. If anyone has questions, we'll keep them towards the end. Once all of the speakers have done it, we'll open up for a panel and questions. Thank you.
Good afternoon, everybody. Myself, Dr. Kadri, I have worked in the capacity of epidemiologist, state surveillance officer under IDSP. It is a communicable disease surveillance program running all over the India. Then I have been heading climate change and human health in my state. Can I have my presentation? Yeah, I'll be talking about the health vulnerability challenges and adaptation opportunities in northern India. The major challenges in northern region, especially in Kashmir, among ambient air pollution, we have vehicular emissions, brick kilns, and road dust. And there are gender-based challenges. People, women especially, living in far-flung areas, they depend on cooking for their meals on solid biomass. And this affects the indoor air pollution. And it has been documented that overcrowding, it leads to early formation of cataract. And there is an entity what's known as Gujar lung. It has been due to the inhalation of smoke from the pine woods. It mimics with the miliary tuberculosis. And earlier, the people have been treated for tuberculosis, though it was not a TB, but it was due to the inhalation of pine wood smoke. The other challenges in far-flung areas, especially in few districts like District Kupwara and Baramulla, we have avalanches and snowstorms. These are the publications which have been already documented regarding the biomass and indoor air pollution due to the inhalation of pine wood smoke. These are the awareness messages which are continuously going on. These are the ladies which are cooking their food on firewood. And this tradition is still continuing in far-flung areas. The climate-sensitive diseases in Kashmir in winter months, which starts from the month of December to March, people are vulnerable to frostbites, chilblains, and CO poisoning because of burning of hard coke to keep themselves warm. Then in winter months, we have exacerbation of acute respiratory infection, COPD, bronchial asthma, and cardiovascular disease and stroke. Then in winter months, we have, due to the overcrowding, we have the outbreaks of measles, chickenpox, and mumps. And in some places at higher reaches, we have the avalanches. In UT of Leh, we are having, it is a UT of J&K. We have in J&K, we have 20 districts, 10 in Kashmir and 10 in Jammu. And in UT of Leh, we have 2 districts, Kargil and Leh. Because of the high index of UV rays, it has been noticed they have early formation of cataract. Then in summer months, which starts from the June to September, we have outbreaks of vector-borne diseases, namely ADD, acute diarrheal disease, cholera, hepatitis A, hepatitis E, and enteric fever, because these are all waterborne diseases. And in spring months, due to the falling of the pollen, we have allergic disorders, especially in the month of May. So these are the hazards of the burning of the hard coke, especially in the winter months. This year in the month of January, single family, 6 members, they died because of the inhalation of the hard coke smoke due to the carbon monoxide poisoning. These are the earlier clippings. 2 laborers died due to the death due to carbon monoxide poisoning. So it is a silent killer. So what are the actions to reduce the emission? As you know, there is a national clean air program which was launched in 2019. Now we need to make more people aware about the EV, electrical vehicles, and reduce the air pollution, and strengthening the other intersectoral coordination among the public. Then clean cooking fuels. There's a scheme known as Ujala scheme, where people are provided with gas stoves instead of burning the wood. Training to improve the improved cook stove and improved ventilation in their households. Though we don't have the problem of crop burning, which is more common in the areas of Punjab and Haryana, then switching to new renewable sources of energy. Adaptation opportunities, then early warning signs, cold wave alerts, we get it, then discourage coke burning, then intersectoral coordination, and a regular monitoring and evaluation reporting mechanism to be placed. Now the best practices, we started this initiative in 2019, that is solarization of health institutes. It was started in one of the sub-district hospitals in district Kulgam, and the name of the hospital was SDH Yaripura. It caters a population of 50,000 population. So this is the solar panel which have been installed there. So installed in 2015, and it has a backup for all the OTs, then offices, computers, and printers. Though there is a backup for the institute as well. This is a video. I don't know why it is not working. It was a video.
Is there a technical glitch?
Yeah. This one. Anyway.
1 second. They're just
Yeah, it is.
okay. It's an image.
No, it's not an image. Anyway.
We will try to
Yeah,
see
yeah.
if it's come back.
So this was recognized as the best practices in the country. These are the awareness messages, the audio, which we put on radio FM and other electronic, print and electronic medias. This is the solarization in different other healthcare institutes as a green initiative. These are the awareness messages we have devised it for in the local language regarding air pollution and health. It is the World Environment Day, which was celebrated in collaboration with Department of Tourism. Thank you.
Thank you, Dr. Kadri. If I may, we'll probably revisit that slide that wasn't working, and perhaps during the panel session, we can just talk about perhaps what the video actually entailed. So so I'll just move on and invite Dr. Amrita for her talk. Thanks.
Thank you all, and thank you for the opportunity. So this case study is the initiative led by the Uttarakhand state with the joint support of the National Institute of Disaster Management, National Center for Disease Control, and US CDC Country Office, India. So I had the opportunity to support the project and lead this pilot project in the Uttarakhand state, and the aim of the project is to support the community and in prevention for and response to public health emergencies that occurred due to climate change. So before we deep down in the project detail, let me discuss about the climate change that refers long-term changes in temperature, weather patterns, and environmental condition. The major causes included the greenhouse gas emissions, deforestation, and the industrial activities. These all changes affecting the people and posing the significant risk to the population. Addressing to all these changes requires a collaborative approach. For example, at the community level, community plays a key important role as a first responder. They ensure the hygiene practices and the safe water use. At the health authorities can lead and conduct the risk assessment, can issues the early warnings, and can provide the medical support. At the local government, they can lead the action plan and the resource mobilization. As the same, regulatory bodies can develop the policies to mitigate the impact of the climate change. And lastly, the training and the awareness drives can build the capacity of the responders and the community members. So this is in 2022, Government of Uttarakhand, with the joint support of the NCDC, NIDM, and CDC India, envisaged an initiative. They called the name of initiative is Kaushalyam. There are 3 core components of the Kaushalyam, and one of the core aspect is public health emergency preparedness and response in a community setting through a community emergency team and the response team. As Uttarakhand state is vulnerable to various kind of disaster and epidemic prone diseases due to its interconnect and inter-state connect or inter-country bordering movement. So the initiative focused on the building the capacity of the public health professional in the public health emergency management. So the initiative started and we developed the assessment tool. While doing the assessment in the community, we realized that there is a need of creating the awareness in the community. There is a need of the capacity building. There is a need to work with whole of the community and also the need of enhancing the knowledge of the community and empowering the community members. So the process of empowering the community involves the series of the meetings, awareness drives, mock drills, with the community members, with the community influencer, with the community leaders. We also involve the community members in the decision making process so that community can take the ownership, and plus if there is any local problem arises, they can address the problems at their own. At the community level, there are different departments are working, so we have included each and every department in this pilot project, from health department, sub center, and the health and wellness center. Now they are the Ayushman Bharat Arogya Mandir, in which ASHA workers, ANM, CHOs, and VHNC members were involved. From PRI Panchayati Raj Institution, Gram Panchayat, from Anganwadi, from ICDS, we have involved the Anganwadi workers. From education departments, we have included the primary school teachers, and we tried to include all the community-based organization who are working in the community, and some volunteers also. We have coordinated this different type of stakeholder consultation and coordinated with the different departments from the state level, in district level, in block level, and in Gram Panchayat level. We also organize a policy level meeting in which Director NCDC from Delhi, Secretary of Disaster Management, Secretary of Health, and Director of Panchayati Raj Institution were involved, and we discussed the overall pilot project and what will be the outcome of this project. So, to control and prevent any risk, community plays an important role, and the community participation is the most effective approach to achieve the sustainability in dealing with any risk. So in the project Public Health Emergency and Preparedness and Response Capacity, we have piloted this project in the Nausar Gram Panchayat of Khatima Block, District Udham Singh Nagar. So first we started with the entry point activities, where we conducted some awareness campaign with the community. We spent time with the community members, and after that we moved on the public health emergency related trainings. In the Gram Panchayat, Gram Panchayat is the smallest unit of the local government, that is the Panchayati Raj system, and the sub center and health and wellness center is the smallest unit of the health system. So they both are very close to the community. So in this pilot project, we have created two types of team. First is community emergency management team, and second is the community emergency response team. So the community emergency management team, CMT, is mainly responsible in the planning, logistic, admin, and the finances. And the CRT, which is mostly involved in the operations part. They create awareness in the community. They detect the clustering of the cases in the community and also report it. They also coordinate in the response mechanism. They also provide the psychological support to the community members. Government and as JP sir also said, that government and community should work together for the better health outcome. So, and it is also important that we should work with the whole community. That's why in the creation of the CMT and CRT members, we have taken the members from the pre-existing structures. Or in case of the increased search capacity requirement, the Gram Panchayat can recruit or select the volunteers from the community to meet the need. We have also involved the district magistrate, director national program, and director Kumau in the pilot of this, in the piloting of this project. So as I have said earlier, that we have started with the entry level activities. So we have created awareness on the Panchayati Raj Divas. We have celebrated the Azadi Ka Amrit Mahotsav. We have created the community dialogue Jan Samvad with the community members. So before the monsoon season hits, we have trained the community members in the flood preparedness, risk reduction, and the response. And after that, we have trained the community in the public health emergencies, preparedness, and the response. And when the monsoon season come, we have seen the changes in the practice of the community members. That community members are familiarized with evacuation routes and the warning signals in the community. They are avoiding walking or driving through the flooded areas and the stagnant water. They are taking measures to protect against mosquito and other waterborne diseases. So this shows that the community well understood their roles and responsibility in regards to managing the any emergencies. Apart from this, we have seen the vulnerability of Uttarakhand state. We have supported the state in the development of village emergency, public health emergency and disaster management plan. This plan has been prepared in the close coordination with the district disaster management cell. These are some glimpses of the media coverage covered during the awareness drives or the capacity building time. These are the photo glimpses which shows the zeal of the community and the participation of the community members. These are the experience sharing from the fields. Fonts are in Hindi, that's why there is problem occur. So these are the sharing of the community members. Thank you.
Thank you very much, Dr. Amrita. I think that was a great presentation that really brought, I think, some of the points this morning on co-creation. So I think fantastic work there. I'd like to now invite one before the last speaker, Ms. Neeta George, and over to you.
Okay. Thank you, Iman, for the warm welcome. I'm Nida George. I work as a health system mitigation and adaptation consultant. Let's move on to the study since it's time about to have lunch. We have conducted an assessment with Healthy Energy Initiative India and the Kerala Health Department. So I am from state of Kerala. 2018, we have faced a massive flood and the damage was so high. Only to our government hospitals, we faced a loss of nearly 120 crores. And some of the districts were worstly affected, like Ernakulam, Pathanamthitta. These districts were worstly affected. We have to evacuate our patient. Our surgeries were suspended. Critical care emergency services all were suspended. So this is where we find the climate vulnerability assessment of public health facilities are so important. So we conducted this assessment in Idukki district of Kerala. So those who might have no idea about Idukki district is one of the 14 districts of Kerala. And this district is very famous for tourism, have a lot of plantation, and it has like major rivers running across the district, like nearly 7 rivers we have. Of that, 2 of them are very major rivers. And our 66% of the state's power, we depend upon the Idukki hydroelectric project. So This is the hazard seasonality mapping of the district by the District Disaster Management Authority. Throughout the year, Idukki district is prone to earthquake, and June, July, we have heavy rains in Kerala. So they are prone to landslides, flooding, and heavy winds also. And March, April, we have summer season. So wildfires and droughts, chances of droughts and wildfires are so high. And throughout the year, there are chances of road and water related accidents. So we have conducted our assessment in 4 hospitals. One is in a primary health center, other is in a community health center, third one is a taluk hospital, and other is a family health center. So we were looking at 2 aspects. One is the infrastructure vulnerability, other is the climate sensitive disease vulnerability. In infrastructure vulnerability, our main focus is what are the past experience the hospital has faced on extreme weather events and what kind of damages they have faced and what are the preparedness measures the hospital has taken to manage those impacts. And we also explore the climate sensitive disease vulnerability. We look at what are the past reporting of climate sensitive diseases and what are the preparedness measures the hospital have taken. So I would like to share the findings from one hospital, is the community health center Vandiperiyar. So Vandiperiyar is like a very small panchayat in Idukki district. This hospital is located in a total 1 acre of land, and they have like 3 buildings. One is an OP building, one is an IP, and one is a staff quarters. And it serves total 43,000 of population. Of that, 200 are tribal population. So when I mentioned about Vandiperiyar town and Idukki, as I told, Idukki is very famous for its plantation, pepper, cardamom, all kind of spices are produced in Idukki. So Vandiperiyar is a small town in Idukki. It's like a trade center in Idukki. So people who come for the trade in the Idukki district, they come to the Vandiperiyar town. So the hospital is very accessible for the people. It's just 1.4 kilometers from this Vandiperiyar town. So these people, they access this hospital. And in front of this hospital is the national highway running. And Kerala we have a very famous pilgrimage center, Sabarimala. So people from South India, they travel across this district and they pass this road to reach Sabarimala. And also this district is very famous for tourism. So during tourist season, people also access this hospital a lot. And above that, most of the people who live in Idukki district, they are mainly working on tea plantation. They are daily wage people. They couldn't afford the private healthcare. So they largely depend upon this government hospital for their treatment. So accessibility of this hospital is very important. So when we look at the infrastructure vulnerability, flood was the major thing which affected this hospital. In the picture, you can see there is a small canal which is running in front of the hospital. So during heavy rain, landslides happen inside the forest, so which result in an increase of water flow in the Periyar River. Periyar is one of the major rivers in Idukki district. So when the water in the Periyar River increases, which also result a backflow of water to this canal, which result a flooding in the hospital premises. And you can see, so when water increases enter into the hospital premises and to the highway which is running in front, what the Panchayat has done is they have raised the height of the highway which is running in front of the hospital. Now what happens is the water from the highway also it enter into the hospital premises. And behind the hospital, it's a tea plantation. So this water from the tea plantation hill also, they are supposed to drain into this canal. So what happened is this water also gets stagnated in the hospital premises. And you can see he's a staff who explained this is a small drainage for the wastewater to go outside. So when the hospital premises get flooding, through this channel, water enters in the hospital. So we try to understand what kind of infrastructure damage or the service delivery damage was occurring when we face extreme weather events. So you can see in the pictures like the hospital staff has marked, I think it is clear to some extent, 2018, 2019, and 2020. These are the years the hospital has been flooded, and the staff in the hospital, they have marked the level of water in the stagnated in the hospital premises. So up to that level, the water was stagnated in the premises. 2018, we hit a massive flood. There was no prior alert. At 5:30 a.m., water entered into the hospital premises, and half of the ground floor was completely submerged underwater. They lost the medical record, medical equipments. Patient have to be evacuated. You can see in the picture the infrastructure damage. The hospital has 2 wells in their premises. One is for drinking, and other for the sanitary purpose. The whole well was completely under the water. And this is the hospital building and the staff quarters. You can see the damage happened during that flood. And service delivery was also highly affected. So what the hospital people has done is when the water level in that canal increases, they look at the post and when the water enters in the hospital premises, they have to literally cut down the electricity supply to the hospital. And there were snakes and scorpions were seen in the hospital premises. Luckily, there was no bite or a damage or a death occurred, but these were seen in the premises. 2018 flood, hospital was flooded. 2019 and 2020 also this hospital was flooded. And health service was affected. Infrastructure was damaged and employees were unable to come to the duty. Patients were also unable to come to the hospital. We understand what are the preparedness measures the hospital has taken to tackle this. The hospital has a rapid response team, which has like medical officers, nurse, and everyone. And the staff who are living nearby the hospital, they are also able to come. But the important thing is the hospital doesn't have a documented disaster management plan. They were able to respond at the time of emergency, but the most of the response mechanism was from the experience of the senior staff. What if the senior staff is not there in the hospital? What if they move out of the hospital? There is no institutional response memory. You can see when the water entered the hospital, these hospital staff have to keep all the equipments above the tables. So when the water entered into the ground floor, they have to move, or in the hospital, inside the hospital, they move all these medical equipment, records, everything to the first floor through ramps. So post-flood, they have raised the height of the well. So the water doesn't contaminate the drinking water. And they have insured all the medical equipment, and that will get renewed in 1 year. They have also had a backup generator and with a diesel generator and 50 liter of backup diesel. And in the post-flood, the staff, the villagers, they all worked together to clean the hospital. Prophylactic medicines were given. We also tried to understand what are the climate-sensitive diseases they were having. So during rainy season, Idiki is like a hill station. So during rainy season and winter season, there were cases of breathing difficulty, asthma, cold, bronchitis, and during summer season, UTI infections were there. And in the post-flood cases, there were snake bites and scorpion bite cases were there in the hospital. And also in the post-flood, there were PTSD cases was also reported. So we try to understand what are the preparedness measures the hospital has taken to handle this. So the staff have received training, but the thing is there is no written or emergency response and a contingency plan in the hospital. So these are some of the key findings we found in your assessment. Infrastructure were damaged in the extreme weather events. Service delivery was affected. There were long power outage, no electricity backup, and there was shortage of diesel fuel also. And when it's come to vulnerability of a hospital, vulnerability vary depend upon the geography. That's something very key. We done our study in 4 hospitals. One hospital was affected by flood. The other hospital, water shortage was the issue. For the other hospital, heavy wind was the issue. So even all these hospitals are within like 10 kilometers, 12 kilometers. But the vulnerability of these hospitals vary depend upon the geography. And we found there is no standard operating procedures or written plans for emergency disaster response. Staff need to have more adequate training on that. And accessibility was highly compromised for the patients as well as for the staff. And there was uprooting of trees. So staff also has a concern on the safety. And they need to have a more efficient coordination with the district disaster management authority. So we come up with few recommendations. So we couldn't move this hospital to another location because this hospital has a lot of accessibility factors. So retrofitting of the healthcare was key in this moment. We also recommended to have a standard operating procedure on disaster response, and the staff should have a training on disaster preparedness and response. And the hospital should be, very important thing is hospitals should be powered with renewable energy because they are clean and they are reliable. And there was a hospital who faced the water shortage, has rainwater facility need to be done. And the hospital should have a contingency plan. That should not be done only by the hospital. There should be an LSD in that, there should be NGOs in that, there should be fire service should be there. At the state level, we come up with few recommendations. All the public facilities in a state should have a climate vulnerability assessment. So depending on the vulnerability, necessary retrofitting of the hospital should be done. And also disaster-specific training should be given to all the staff. And hospitals in the state should have a disaster management plan. And long-term, hospitals should have a supply of renewable energy. So when it comes to the key part, we done our study. We take the result to the stakeholders. We conduct a stakeholder meeting. So all the medical officers in the hospital were there, the district health authority were there, local self-government there. So our preliminary objective was to disseminate our finding and to identify key mitigation strategies to come out of this impact. So once we had the discussion, so LSG offered their support in remodeling the canal in front of the hospital. LSG had provided the support in the hospital who faced water scarcity. LSG offered their support in rainwater harvesting, borewell. And also all the doctors or the medical personnel, they reiterate the importance of having the solarization in the health facility. So we released this report in coordination with the district collector. So before concluding, I would like to take you back to the stakeholder meeting. So end of the stakeholder meeting, when we're having a conversation with the panchayat and with all the medical staff, one of the common things that came up from them is that even though every department has its own priority, they are working on that priority. They don't get a chance to sit together in a table and discuss these problems. So when they get an opportunity to sit in a table, discuss the problem, the solutions are coming up. The LSC offered their support. This is where the local actions, the interdepartmental coordinations are key. So I would like to conclude by saying there are public health facilities are highly affected due to climate vulnerabilities. That is where your localized actions play a key role and intersectoral coordination plays a key role. Thank you.
Thank you, Neeta. I will just now invite Dr. Panda to give our final presentation. Thank you.
Very good afternoon to one and all present here. My esteemed panelists on the dais, speakers of the dais, scholars, academicians, researchers, representatives from the media houses and organizations in public health practice. At the very outset, I want to congratulate Access Health International for organizing this conclave, especially to Dr. Reddy for creating such an inclusive agenda in the forefront of public health discourses in our country. Am I audible? I hope I am. The purpose is more important than the processes, I feel. And the purpose of this conclave is actually, it is unique in many ways. I was very critically analyzing it. It gives us opportunities to commemorate the beginning of a disaster that struck us 5 years back. And it also gives us the opportunity to identify possible solutions, challenges ahead, and possible solutions to sail through some of these problems which are likely to come in the years, months and years to come. So at the very outset, this conclave is unique in many ways. I was also listening very patiently to some of the speakers, especially JP sir, Professor Sundaraman sir, Professor Reddy sir, and Professor Malarao ma'am. Ma'am is standing there for a long time. I'm watching, ma'am. Please take a seat. So these are very interesting conversations, and I feel I'm standing here both as a student and also as a professor. Because I have been hearing and listening and learning from all the discourses that is happening at the back door of this health system's resilience, health system strengthening, and climate change, and etc. My panelists on the dais in this particular session have been talking about different facets of climate change and health action. Today, I'll be speaking exclusively about this heat stress management and vulnerability assessment in Odisha context. But beyond this, at the very beginning, I want to actually introduce health system in India with 3 paradoxical features. I think Professor Sundaraman sir has already spoken about it, but again, I want to re-emphasize. Probably the only health system in the world which is very loosely regulated. The only health system in the world where the government spending on healthcare is abysmally low as compared to even neighboring countries like Pakistan and Bangladesh. And the only health system in the entire world where the role of private sector is prominently visible, even when we have about 1/3 of the population living below poverty line, and about 1/3 of them still illiterate. So with these 3 paradoxicalities, do we have a role to play? Yes, we have very important roles to play. As academicians, researchers, leaders, community engagement officers, and public health advocacy personnel, and NGO representatives, and government representatives, I had discussion points with Prasanna ji last evening and today morning, and we have been talking 1.5 because he is now actually handling the government affairs in Chhattisgarh, and with several bureaucrats back in Odisha and elsewhere as to what should be the role of the government. Our Prime Minister has been talking about, maximum governance and minimum of government, and maybe that could be one of the epidemiological dividends or demographic dividends, or maybe democratic dividends, you can say, that is getting accumulated in our country over a period of time. But nevertheless, there are questions to be answered. For example, we started at the same parlance with China. 50 years down the line, we are 1/6 of the GDP of China. Have we progressed? Yes, we have. Whether areas of concerns there were, are there any opportunities to grow further? There are definitely. So under these circumstances, I'll be talking exclusively about vulnerability and heat stress in Odisha context. Theoretical discourses on heat stress, I'll not take you through because I'm standing between you and your lunch, and I don't want to extend it beyond a point of time. But heat stress is a genuine problem that is now hampering our day-to-day businesses life everywhere in the country, especially in cities, small towns, and places like Bhubaneswar, New Delhi, and even some of the states where panelists are belonging from. I'm sure they all will agree that heat stress is emerging as a major challenge for our day-to-day life. We continue to live in air-conditioned rooms, and even our day-to-day practices also, while traveling, we are catching a cab which is air-conditioned, and that is ultimately creating a vicious cycle of even producing more heat stress-related islands within the cities and towns. If not mitigated, this can result in severe health outcomes. We all know that my own study in Bhubaneswar 2019-2020, I'll be presenting some of the key findings, very clearly indicate that heat stress can leads to a loss of productivity in terms of economic productivity, and also it creates a vulnerable health condition, especially for the vulnerable segment of the population, including pregnant women, young kids, elderly population, and daily laborers, traffic police. We have very closely engaged with the traffic police personnel in government of Odisha level to offer them solutions, because we must appreciate that the traffic police stands right on the sunlight, even throughout the day, without any protection. So under these circumstances, they are exposed to a lot of vulnerable situations in terms of health and economic losses. The impact, as I told you, health impact, economic impact, and social impact. Health impact can range from severe conditions like heat stroke and death to moderately severe conditions like dehydration, and then other syncopes kind of conditions, loss of consciousness for a temporary period of time, and then exacerbation of some of the existing chronic conditions. Economic impacts, study indicates that there is significant loss of economic productivity, because the daily workforce and people who are working during the daytime, they lose out at least average of few days of wage losses during these extreme climate conditions. Then there is also social impact in terms of creating stressful situations, and then leading to both migration, in and out migration, and then community health risks. So frequent health stress, heat stress is posing critical public health problems in Odisha. And we in Odisha, especially Bhubaneswar town, some of the towns like Jharsuguda, Angul, Sambalpur, Titlagarh, Mayurbhanj, Balangir, that entire western belt of Odisha, and even the main towns of Bhubaneswar and Puri and places like the coastal belt, there are huge differences in the temperature during the entire year. Seasonal variations are predominantly visible, because of which people are having a lot of discomfort, not just because of the temperature, but also because of the associated humidity. The 1998 heat wave for the first time claimed about 2,000 lives. And that is where the government realized that this is not just an imaginary problem, this is a real problem at our hand to deal with. And that is also where Odisha has been facing a lot of cyclones. The government of Odisha established a nodal agency called the OSDMA, Odisha State Disaster Management Authority, empowered to take all the decisions right from policy to action with respect to addressing these climate vulnerability issues, floods, famines, calamities, cyclones, and heat waves. So despite the government intervention, the heat-related morbidity and mortality, they remain a concern. I was trying to extrapolate data from OSDMA. This is official data from 1998 till 2018. This 20 years data, I personally feel this is grossly underreported. But still, they indicate that there are accumulative deaths that are taking place that can be ascribed to heat stress conditions. My study basically focused on vulnerability. My previous speaker actually spoke about vulnerability assessment in institutional settings, but my study was basically at the community level. So we identified about 10 hotspots clusters in Bhubaneswar city, which were recording high temperatures as compared to few other shaded areas. And then we tried to conduct household surveys in those hotspots of about, say, 25 to 30 randomly selected households from each of those clusters. What were the findings? The key findings were basically categorized into three groups. One is the key symptoms, second is the mechanisms that they're adopting to cope up with, and what are the challenges they still continue to face in the wake of this heat stress exposure. Sweating, headache, and dehydration, they were cited as three most important and frequently presented symptoms of exposed to heat stress. And the coping mechanisms included using fans, staying hydrated, and modifying the work hours. And that's what I was telling you, that there is a significant loss of work hours and leading to significant loss of economic productivity, mainly because of this reason. And then the challenges that continue to exist are basically cooling infrastructure. In a city like Bhubaneswar, I'm sure for that matter, in most part of our country, the personal cooling strategies, adaptation of personal cooling strategies, awareness about those strategies, and government preparedness to deal with those, to popularizing those strategies are relatively weak. Therefore, personal cooling strategies cannot be just dependent on air conditioning. Air conditioning is not the answer to deal with heat stress, because it will have even long-term consequences, which are going to be even more devastating. So therefore, personal cooling strategies will range from taking a bath to sprinkling water to using a pedestal fan to apply or stay in the house which is having windows and well ventilated windows. Those are the options. And then rooftop cooling technologies, which comprise of simple solutions like coloring the rooftop to using these halo balls for inverse cementing of the rooftops. Those are some of the technologies which have been now popularized in India. Those are going to be the long-term solutions. So I think I can see 50 years down, probably our next generation are going to live in the clay houses, which we started 50 years back. We are actually, the cycle is going in that direction, because ultimately that's going to be the more sustainable model for offering us solutions to deal with these climate vulnerable conditions. So findings, they show that there is a huge variation with respect to the vulnerability due to geography and socioeconomic factors. People who are better off economically, they can go for installing an air conditioner in their houses. But slum dwellers, daily workers, rickshaw pullers, auto drivers, and traffic police, they do not have the luxury of going to resort to the air conditioners. Fortunately, this study was cited in the OSDMA heat stress action plan taken report, and I'm a resource person there. So every year they conduct a meeting, I go there and then contribute to the discussions with the government of Odisha officials for creating a population friendly, community involving, and decentralized mechanism plan of action for the twin city of Bhubaneswar and Cuttack that normally gets into place every month, March. So for the 3 months of March, April, and May, because monsoon will hit Bhubaneswar on 15th of June. So for these 3 months of high intensity heat and humidity, people will have to be made aware about do's and don'ts. And these heat action plans for these twin cities actually are aimed at solving those problems and integrating. The madam spoke about interdepartmental convergence. So integrating different departments in terms of their segregating their roles, and then at the same time offering the convergence points for taking community-based actions are going to be the focus of those heat action plans, which are being developed for this twin city of Bhubaneswar and Cuttack. But there are infrastructural gaps, they exist, and the government is aware of those gaps. Subsequently, we are trying to now propose for conducting similar studies even for small towns, because I realized that in this study, I have not presented the key findings, all the findings, some of the, but realized that there is a difference of about 3 to 4 degrees within the city of Bhubaneswar. There are heat islands where the heat gets percolated down and it doesn't get out, mainly because of the the terrain. And for example, places nearer to the airport, places nearer to the barren lands, places nearer to the main activity, geographic, the economic activity hub of the Bhubaneswar city, there is 3 to 4 degree temperature more as compared to places which are far up, little far up from Bhubaneswar, which are surrounded by, there is a beautiful scenic beauty of Bhubaneswar city, but Unfortunately, that is also being degraded over a period of time. This is Chandaka forest is there, which is about 5 kilometers away from Bhubaneswar. That was the main natural protector and offering that, buffer climate zone for the Bhubaneswar city. But unfortunately, that is getting faded out. So now this kind of a vulnerability assessment and threshold analysis, we also conducted a threshold analysis. There's a paper published on it. Is important for us to find out at what tipping temperature, beyond it, the all-cause mortality cases are on the rise. And for Bhubaneswar, it is being, in our study, we found it is about 40.5 degree Celsius. So similar studies need to be conducted for small towns, and localized actions need to be taken. The community must be at the center of this decision-making process. Jayaprakash sir spoke about the 73rd and 74th amendments. Both the amendments happened in the same year, 1992. And both amendments, he spoke about the negative sides, but there are also a few positive sides. Is that at least now there is a municipality which has got a constitutional status. There is a panchayat which has got a constitutional status. People have got every right to question their local self-government as to what they are doing during the periods of crisis, including a heat stress situation. So that opportunity is now given to the citizenry. I will not actually get into whether they have been successful. That is a different discourse, but at least that opportunity is there. So this localized action points developments, empowering communities, involving them in decision-making process, and creating localized natural buffer systems in terms of forestation, shadings, clay houses, personalized cooling strategies, and less dependence on artificial infrastructures like air conditioning and use of plastics and those environmentally hazardous materials are going to give us the solutions over a period of maybe 2 to 3 decades. This climate reversal, climate reversal is something that is now the focus of our discourse, international discourses. So therefore, in this context, I feel I'm thankful to Access Health for devoting a session on the importance of climate resilience healthcare system. And thanks once again to all the panelists who spoke about different dimensions of climate change and their impact on health. I look forward to have more interactions, debates, deliberations, collaborative work in this domain with all the stakeholders, important stakeholders present both within the house and outside the house. Once again, thank you all. Have a good time. Thank you.
Thank you, Dr. Panda. Okay. I'm going to just open up for questions in a minute or two. But before that, Dr. Khadri, very sorry about the unfortunate tech thing, but now we are able to play the video. So what I would like to do is invite you to maybe just walk us through that video segment. Yep, thank you. If you'd like, you can actually sit there and you'll be able to see from there, whichever you prefer. Thank you.
But it will, there's something can be forward a little bit, if we fix that.
There's a technical glitch again. These things happen. Sorry about that. I'd like to invite anyone in the audience to take questions now. Thank you. Do we have mics in the audience? If not, yeah, let me just. Will someone please?
Do you have mics in here?
Yeah, I know.
Vijay.
Hi, good afternoon. I'm Dr. Manoj from KHPD Bangalore. First of all, fantastic panel discussion and so insightful case studies presented. My question is regarding the climate resilient health systems we are talking in this particular session. But more often we are seeing in India and abroad also, more of the intervention centered around facility, not really community-centric resilient climate models are coming up. Talking particularly of health stress. So my question might be centered to direct it to Dr. Bhuputra. So we are talking of community should be in the center of decision making, but if you see in the hindsight, more of the interventions are centered around facility, like we're talking of solar roofs, even clean energy at the facility. So what about the community? Once sometime when they feel sick, they can access the facility, but what about the housing, infrastructure, even access to the facility, mobility also, contributed lots to the climate change. That's my first question. Second is a follow-up question regarding heat wave itself is not considered as the broader pandemic framework in India. Although we're talking of 2000 lives claimed in 1998, but still it is not considered as a broad, the way cyclone and floods has been considered. So what is your, kind of thoughts about it? Thank you.
I'll answer the second question first, because that's more of a conceptual question as to why heat stress is not being considered so seriously in Indian context. It's mainly because, just as, for example, you must have seen that the natural tendency of the human population and also the governments have been to respond to issues which are of immediate problem rather than something which is little distant. And heat stress was always considered to be something which the adaptation of which government felt it is an individual's own responsibility. If धूप हो रहा है तो बाहर मत जाओ, हम क्या करें? So that kind of a response it was, and that is where we have traveled all this way for last 2 decades. Governments have now started moving on. They have established mechanisms, as I told you, Odisha context. I'm sure in Chhattisgarh, Kerala, Uttarakhand, and other places also, I'm sure now systems and processes are in place, SOPs are in place as to what to do, who is going to do what when there is a disaster, including a heat stress situation. The second thing is that heat stress, it is very difficult to ascertain the cause of death to heat stress. It is a clinical diagnosis that need to be done by the medical officer. Suppose somebody is dying at a PHC, unless and until the medical officer himself is trained, it is difficult to diagnose and then write the cause of the death as heat stress. And we have seen ourselves that the understanding, the literacy about heat stress, heat vulnerability, syncope, dehydration, and fatigue, and then that leads to loss of consciousness and subsequently heat stroke and death. That understanding has to be instilled in medical officers. Because of these 2 reasons, even when deaths were happening because of heat stress, they were underreported. And therefore, what we did is we tried to find out all-cause mortality beyond. So basically, on the one hand, you have an x-axis temperature, and on the y-axis, all-cause mortality. And then figure out whether there is an association between increase in the all-cause mortality, because all-cause mortality, you can't hide it. It has to come. And then we realized that yes, beyond a tipping temperature of 40.5 degree, suddenly the all-cause mortality graph is rising. So therefore, the threshold analysis, as I was talking about, is basically to find out what is that temperature beyond which people's response mechanism, own biological response mechanism suffers and leading to loss of lives. The second question that you asked about is why the community involvement is relatively less. Again, the answer has been the Alma-Ata Declaration 1978. I'll go back. We came back and gave a popular slogan of health for all by 2000. But what was the situation of health condition in 2000? Health for all in 2000, and the proposed strategy in the Alma-Ata conference was community participation. These were the 2 important milestones set forth in 1978 Alma-Ata. But 22 years down the line, when we analyzed and realized that health for all by 2000 could not be achieved, one of the main barriers to this was poor community participation. Even though explicitly mentioned that community participation is going to be the preferred strategy. Similarly, now also, since the year 2000 onwards, Millennium Development Goals, now Sustainable Development Goals, everywhere the center of the discourse is community. But I was telling Dr. Reddy sir that Access Health is actually working on a very interesting idea of health literacy. And one of the team members, 2 or 3 members are working on that area. That is the future of our country. Because unless and until you create an empowered community, a community which is being aware about what are the possible problems at hand and what are the possible solutions at hand, community participation cannot be done. And governments, of course, have become more sensitized, more responsive now. but the health system will have to travel a long way in terms of setting the introducing those midterm corrections and then engaging with the community. The distrust, the distrust between the government and the non-government, that has now come down. The National Health Policy 2017, now it is explicitly talking about the role of private sector in healthcare, and therefore the governments have also realized that they cannot ignore a private sector. So having this concerted and collaborated effort, both by the government and the private and non-government organizations, aimed at empowering communities through health literacy, through education, communication, behavior change, information, dissemination, sharing of knowledge is the way ahead of us. So that is what is my own take on this. Thank you. Yeah.
In Chhattisgarh, northern Chhattisgarh, there is an area called as Sarguja, where one organization with funding of Tata Trust, they're actually sitting with the communities and they're just discussing with them how they are coping up with this climate change. Because climate change, to be practical, it's not a very new concept, it's there for thousands of years, and the communities have been adjusting over a period of time for the climate changes. So they're already on the job of mapping it, and once the documentation is done, many of these things have come as a policy in Chhattisgarh government. Hopefully it will be adopted. And second, Gram Panchayats also, they have been asked to identify one of the SDG goals as their top priority and work on it. So few of the Gram Panchayats in Chhattisgarh, they have adopted this climate resilient thing and they are working on it also. Maybe in the times to come, so the involvement of the community will be able to document it. And once we have some good concrete examples, then it will be converted into policy making.
Thank you, Ms. Prasanna.
I would like to add one more point. So you're saying something? No, I would like to add one more point, like what Sir has said. We cannot, to some extent, when we make the hospital resilient, we are making the community also resilient. We have documented a small study from Chhattisgarh, actually. That's a rural part of Chhattisgarh. It's a tribal village where the woman or the people who live in that village have to walk so far to get the health service. So the State Health Resource Center, the CREDA, and the health department, they have made a family wellness center. They have solarized the hospital. So the women are feeling safety to come to the hospital. They have also provided a solar equipment. Through that, the water supply is continuously there to the village. So the villagers in the evening, this is a tribal village. These people, they come to the hospital. They were chit-chatting in the hospital. They have water connection to their to some or other extent to their houses. So if you make a hospital resilient, along with that, the community which is living near to that hospital also is getting resilient. Thank you.
Thank you, Nita.
So just a couple of comments. And it's very interesting what you said about the health impacts of heat exposure. That you've talked about the acute part. There is another dimension to it. This is a chronic exposure to heat, particularly in semi-skilled and unskilled workers, that leads to repetitive kidney injury. And then there's a lifetime loss, right? That's one part. The other part is, in large part, this is a self-inflicted problem because we have created concrete jungles with inadequate ventilation. And the worst examples are our healthcare facilities, where not only are the buildings poorly designed for lack of ventilation, but even those poorly designed buildings, our people close the windows and doors and further reduce the ventilation. So we've actually done a project in Mumbai to help people in the government sector, 160 odd hospitals in the Mumbai Municipal Corporation, simply to open windows and doors and move furniture around so that they could allow adequate ventilation into the facilities that lacked air conditioning and so on and so forth. We don't want air conditioning. We want ventilation and management of the temperature by using less energy, by building better design facilities.
Just to add, I just want to add one more point here. This personal cooling strategies I spoke about also includes use of a pedestal fan. Now, studies are indicating that the temperature difference within the room between using the ceiling fan and pedestal fan is about 2 degrees. If you're using a ceiling fan, and using a pedestal fan, there is a difference about 2 degree temperature. People are not aware. People are not aware. This is simple physics. All the hot air will travel around in the upper layer of the room. All the cool air will be in the down. So simple physics also, it becomes important for people. And how many households will have a pedestal fan? For example, I have consciously taken a decision to put up a pedestal fan in my bedroom. When visitors come, they laugh at me. I say, what are you saying? You're using a pedestal fan, which is like year-old tradition. 50 years before people used to do that. So this is also a very important personal cooling strategy, which can save us from 2 degree higher exposure to higher temperature. Similar such small but very effective personal cooling strategies can be adopted at the community level, and that will have the ability of addressing heat stress in a more environmentally sustainable manner. So this is the point I wanted to make. Thank you.
Thank you, Dr. Panda. I have to stop the questions, I'm afraid. Sorry about the time.
last-
For a moment. I'd have to bring that
Last-
up, Dr. Khadri.
last
Just 1
very-
second, please. I'll come back to you 1 minute. I'd like Mr. Khadri to have the opportunity to finish his quick video that's now ready to play, and then we'll come back to you for one last quick question, please, and then we can close. Thank you. Dr. Khadri, do you have a mic with you? Yeah.
This is the solarization in one of our district hospitals.
Dr. Khadri, I have a question for you.
Yeah.
In response to the solarization. Are there challenges in your particular region in being able to actually implement? Because there are certain nuances politically as well. And there are many other factors also to coordinate. So how difficult was it for you to be able to run this program?
Yeah, basically this is a government initiative, Ujala. And another is PM Solar Initiative. It has been devised from that program only, and not much of the, you can say, difficult for implementing these. It's an ongoing process. And regarding the disease surveillance, I will just say the temperatures are changing. We have extremes of temperature right now. In summer months, our temperatures never used to cross 35. Last year, it crossed 37 degrees centigrade. And in winter months, it goes below -10. And this year, we had -12. So there is early apprehension of that vector-borne disease. We never used to get vector-borne disease. Like in Jammu, we have vector-borne disease like dengue, malaria, chikungunya, but not in Kashmir. Now there is apprehension of getting these vector-borne disease. We used to get we never used to get the indigenous cases. We get the travel-related. They have history of travel. So they were, because our being a touristic state, they get diagnosed there. So now the temperatures are shaking. We have to keep our fingers crossed. There is early apprehension of getting malaria and other vector-borne disease in Kashmir, and it won't be a news to us. It will be because we are heading towards it.
Thank you, Dr. Khadri. Just one last question with the gentleman over there. Yes, thank you.
Thank you. So I don't want to be an obstacle between all of you and the lunch. I'll be very brief. So my question to Dr. Kadri and others. So let me introduce myself. Mirza Tausif Beg from Save the Children, along with my colleague, Dr. Tanvi. So we are actually implementing a pneumonia management project in Jammu and Kashmir. Mainly focuses on the Srinagar division. And, we are working very closely with the system. It's a system strengthening project. Now my question is that we have just completed the, baseline assessment and the studies. And we find that, Kangdi, one of the product that is used during the winters, to provide, heat to the family. Now, as you know that when you talk about pneumonia, so we have prevent, protect, and treatment approaches, the interventions, and indoor air pollution is one of the cause. Now, Kangdi is very much responsible for this indoor air pollution. So my question to the esteemed panelists, or anybody can answer, how we can replicate it. It's a long custom, and it's a long kind of tradition that is happening, and community is very apprehensive. They are not, very receptive to, change that habit. So, how come, as an organization, we can work with the community and just try to find out some kind of solutions so that indoor air pollution, it can be reduced. I'm not saying 100% it can be off, but then it can be reduced with any kind of sort of intervention. So this is my question.
But
Thank you.
I must say here now the agriculture is getting a bit lower because we have different heating mechanisms now. We have underground heatings and other things. And cancer has been reported long back in Lawan Valley, surgical medicine. But now things have changed and we have more problem with the hard coke, burning of Bukharis, hard coke. And every year we get deaths due to CO poisoning. And this is a continuous process. And every year once we start the winter, there's an advisory from Department of Health regarding CO poisoning. But nobody is listening. People are dying because of it due to overcrowding. And again, they are listening to it and just ignoring the things.
Thank you. I'm going to have to close the session. I know this is it's great to have conversations going. So what I'd like to do instead is to invite anyone to approach the panelists over lunch and in the hallways as you go abroad. And we'll keep in mind all of these aspects in our next conclave. And so hope we can pick up back again. Thank you.
Great insights, and things never stop. So we have to continue to go on. Thank you, panelists, and thank you, Iman, for moderating this session. I have a wall of resilience outside with pink post-its, blue post-its, sorry. How can I? And those post-its are meant for telling us what you think is resilience. The voice of resilience is that wall, and it needs to get covered before the end of the day. So the blue post-its are for people to write, and we'll help you put it high or low as you'd want it. Those of you who are interested in the breakout sessions, there are breakout sessions on the other side of the building, and there's an arrow that points towards it. Please check your agendas, and you can join in there too.